Okay, so our next presenter, I'm proud to present, is Sobia Kamal.
Good afternoon, everyone. So my practicum was at Alberta Health Services, which is the provincial health authority for the province of Alberta. Specifically, I was in the Edmonton zone. The department I was placed at is looking at an initiative called Triple Aim. This is a healthcare improvement initiative. It's developed by the Institute for Healthcare Improvement. And it's called Triple Aim because there are three primary objectives. First off, to improve the health status of a defined population, to improve the individual experience of care, and to reduce per capita costs. The reason they're looking at this approach is because about 5% of Alberta's population accounts for about 66% of healthcare costs. Specifically, Alberta Health Services is looking at East Edmonton because this community has the lowest socioeconomic status in the city as well as the highest prevalence of chronic diseases. So what they did is they looked at the populations in East Edmonton that are using the most acute care resources, and they clustered them into 6 different categories, which you can see listed here. So far, the team has looked mostly at complex older adults and haven't really looked at the other groups in detail yet. So my task was to look at high needs children and complex infants and toddlers, the 2 last groups you see listed here. So my deliverable for the team was a needs assessment that aimed to answer this question: what are the challenges that impact health status and health equity for high needs children and complex infants and toddlers in East Edmonton? So to answer this question, I relied mostly on speaking to professionals in the community who work with one or both of those populations, providing health-related services. To avoid the need for ethics approval, I opted for informal consultations rather than formal structured interviews. So in total, I spoke with about 13 professionals at 10 different agencies. I tried to aim for a range of different types of agencies. Some of them were child and family services, hospital outpatient programs, mental health services, and smaller nonprofit organizations in the community. So I spoke to them about the types of issues that these populations face in the community, as well as the types of challenges and barriers to care that they face as well. So here is just a brief summary of some of the health-related issues that they present with. So as you can see, high needs children may have developmental delays, cerebral palsy is an issue, various syndromes, ADHD, and other learning disabilities are major concerns in the community. Suspected FASD is also a major concern in East Edmonton. For complex infants and toddlers, many of them have complications resulting from prematurity, such as respiratory issues. And prenatal exposure to drugs and alcohol is also a major concern. So regarding the barriers to health equity in this community, they fall primarily into 2 different categories. I'll just go over each one. So the first category is issues with service availability. First off, there is a shortage of family doctors that was identified by a few people I spoke to. This is a problem because without a family physician, families end up having to rely mostly on medi-centers and emergency departments. And as a result, there's a lack of consistency of care for these kids. And as a result, emerging issues may get missed. Secondly, there are long wait lists for certain services, for example, children's home care, as well as specialist services such as occupational therapists and speech pathologists. The wait can be up to 2 years in some cases. Thirdly, there are difficulties getting the word out that certain services exist. If a family doesn't know that a certain service exists, it's hard to connect them to that service. And if they don't have a family doctor, it's even harder to make the connection. And fourth, there is a lack of coordination with other institutions in the community. A few people I spoke to actually highlighted schools as being the weak link in this regard. Schools do have some support, such as mentors and counselors, and they do try to provide as much support as possible for high needs children, but there is a lack of funding, a lack of time, and just heavy workloads in general that make this difficult. So the second category of barriers to health equity are the conditions experienced by disadvantaged families. First off, there are difficulties related to the parents' capabilities. By this I mean that several people I spoke to identified the fact that the system is very complex to navigate. It's hard enough to navigate if you're a middle-class parent with a reasonable educational level, but if you have a lower health literacy, it becomes even more challenging to navigate the system. Also, raising a high-needs child requires a certain capacity for advocacy, and not every parent shares this skill. Secondly, language barriers are a major concern as well, especially in East Edmonton. This community has the highest proportion of new immigrants to the city. There are translation services available in hospitals as well as other organizations, but even so, language barriers are a major challenge to overcome for a lot of families. Thirdly, barriers related to low income. So a lot of the services that I looked at in the community are actually available mostly on appointment basis, Monday to Friday, normal working hours, which is all fine and good if you're a middle-class parent and you can take that time off work to take your child to your appointments. But for a lot of people working low-income jobs, this becomes quite a challenge. And on top of that, there are issues with coordinating transportation as well as childcare. So as a result, a lot of appointments for lower income families do get missed or canceled. Other issues with low income come along with having to afford special equipment for high needs children, as well as special assessments that some high needs children need. And fourth, barriers related to other determinants of health. So as I noted earlier, East Edmonton is an area of low socioeconomic status, so there are quite a few issues that come along with poverty, such as food insecurity, as well as poor quality housing. A lot of families live in social housing, and I've heard of issues of overcrowding, pests, lack of wheelchair accessibility, and other related challenges. So implications for public health, obviously there's a need to improve access to services and reorient them so that they're more accessible to low-income families. There is also a need to provide programming in more familiar, low-stigma settings, such as providing home visits and more school programming. Thirdly, there is a need to strengthen the role of schools. This was highlighted by multiple people I spoke to. And for this, of course, we need more funding to public schools. And of course, providing greater access to prenatal care, which can help to reduce poor birth outcomes in the first place. And to promote longer-term health outcomes, acting on the social determinants of health with healthier public policies is a must. Obviously, all the determinants are relevant in some way to these populations, but some of the most relevant ones that came up in my discussions are income, affordable housing, and early childhood development. So a couple of the strengths of my project. First off, it addresses a knowledge gap for the team. As I said before, they haven't really looked at these population groups in detail yet, so it kind of provides a first step to having a greater understanding of their needs in the community. Secondly, my findings were actually quite consistent with a literature review that I performed early on in the project. A lot of the same barriers have come up in other countries in the US and the UK as well. A major challenge for me was using a non-research approach. By this I mean that I had ethical restrictions. Obviously, without ethical approval, I couldn't approach the families themselves, and I would have liked to do that, to talk to them about what they see as their priorities and their challenges that they've met in person. So in conclusion, I would recommend personally a more comprehensive needs assessment, preferably using research methods and including members of the target population. And then applying this information to provide a shift in care to meet their self-identified priorities, promoting health equity, and decreasing acute care demand, ideally. I'd like to thank the following people: my supervisor, Crispin Kantz, UVic faculty, my first and second readers, Kathy Worthington, Jeff Redding, Victoria Barr and Betty Taylor for their practicum support, all the contacts I consulted with, and all of my colleagues in this cohort. Thank you.